Okay, good afternoon, everybody. We've been told to keep time very tight and on time, so that's the only job I have this afternoon, so that's what I'm doing. My name's Mary Forehand. I'll be one of the chairs for today's session. Just ask that you make sure your phones are on silent. I've been hearing a lot of phones throughout the day, so I just thought I would remind people. We've got three incredible speakers for this last formal session of the day, although there is the plenary talk at 5:30. And we want to make sure that they have ample time. Each speaker will be presenting for 15 minutes or so and giving some time for questions. So we'll be able to field some questions in between each speaker. And if time permits at the end, we'll open it up to general questions. Okay, so our first speaker is on my phone. I know her, but I want to actually read her bio that she submitted. Is Dr. Angela Alberga. I probably butchered that, sorry, Angela. And she's our first speaker. She's currently an assistant professor in the Department of Exercise Science at Concordia University. Dr. Alberga was awarded the Canadian Diabetes Association Doctoral Research Award for her research focused on improving the cardiometabolic health of children and adolescents with obesity through exercise. So please join me in welcoming Dr. Alberga.
That was actually pretty good, Mary. Usually I get algebra or Alberta, the province, so I thought that was pretty good, considering I'm Italian. You said it pretty well. So I actually don't have any conflicts of interest, but I'd like to thank Mary for the warm introduction. And I also really want to thank the organizing committee for welcoming here today. And I always feel so privileged and honored to be speaking alongside my wonderful women colleagues. So I'm excited to be here. So thank you for having me and thank you for listening. So today I'm going to be talking about weight bias and what can we actually do about it. So first off, before I actually get into some of the research I want to present, first off, I would like for you to take a look at this image. And I want you to notice that the person on your left-hand side is a person of a larger frame, and the person on your right-hand side is a person of a smaller frame. And I'm going to put up words, and I'd like for you to make the associations between the words and the frame that you associate those words with. First one is marathon runner, organized, knitter, junk food, canoeing, good leader, and socially awkward. So if I put up those words and I tell you that I'm actually speaking about, when I speak about being organized and being proactive and a leader, I'm actually talking about my friend on the left-hand side who's in a larger body frame. She's actually really proactive. She's always been known for her leadership skills. She's quite extroverted, loves her canoe trips on the weekends, loves them in the summer, and actually completed about 5 marathons already this year. So she actually is quite active. And that's my friend with the larger body frame. And if I was to tell you more about my friend on your right-hand side, she's actually a knitter. She's quite introverted. She's a little bit socially awkward, doesn't really like to be that organized, but really loves her junk food. Now, if I was to tell you those associations, do those differ from the ones that you made in your head? They might, and that's okay if they do. But we do have to realize that that's actually some of our implicit biases. And what you just did is you actually just did a form of an implicit association test, associating words with figures just based on people's body sizes. So this is a way that we actually measure some forms of implicit bias. Now we know we're very familiar with weight bias and how prevalent it is and how pervasive it is, not only just in the media and so many different TV, radio stations, and also in movies and TV shows, but also in public health. And Ximena is going to speak a lot more about that later. But we've seen this in public health, not only just in the Canadian system, but in the American system as well, and even in the education system. So this happens really often. It's pervasive in all different sectors, and we know that it has several different consequences. Now, as we speak about weight bias, it is quite important, though, to understand its forms, because it exists in various different forms. And these are 3 categories that we usually talk about weight bias in. Implicit, being unconscious. So these are the ones that we're not always usually aware of, but it's important to do self-reflection to be aware of them. Internalized is that belief that weight stigma is actually deserved. It's a form of self-stigma. And there's also explicit stigma, which is much more overt forms of discrimination. These can be subtle, overt, or in relational or physical forms. More obvious examples of these are name-calling, teasing, bullying, verbal aggression, and physical aggression, but also relational victimization. This may not be as obvious, but it's also through forms of social exclusion, not including someone, being ignored, or being the subject of rumors and other name-calling. There are so many consequences of weight bias, and I'm just going to mention a few of these here. Rebecca Pohl and her colleagues summarize these health consequences through the stress experience of weight stigma, and these include eating and physical activity behaviors that can get affected, so avoidance of physical activity, binge eating to cope with the stigma that's experienced, physiological reactivity, even observed through increased cortisol levels, increased blood pressure, and other variables. Healthcare services, so if you experience this type of stigma, you may actually avoid the healthcare system, avoid screening tests, avoid going to see your health doctor. And this may actually ensue in further weight gain, which may also cause more psychological distress and more physiological health and other issues in our physiology. So these consequences are pervasive, and the Canadian Obesity Network has been really strong in keeping this as one of their main priorities of the network, and we've done quite a few initiatives to address weight stigma. And the first actually was done in 2011. This was actually spearheaded by Dr. Mary Foran, who introduced me, and colleagues here, and also the Canadian Obesity Network was the partner to establish this first Weight Bias Summit. It was really to bring about awareness. It was the first Canadian summit held in Toronto. And then from there, we continued with various different Canadian initiatives. In 2013, the Provincial British Health Authority and actually British Columbia, they put out a really important document to address weight stigma and the complexity of obesity, especially the importance of addressing this amongst health professionals. And then in 2015, my colleagues and I organized the second Weight Bias Summit, and this was held at the University of Calgary. Many of you in this room were actually there and present. And what we did was we actually organized several different talks and discussions to really push forward the research agenda of weight bias. So the second Weight Bias Summit was a partnership with the Canadian Obesity Network and several members here. We got funding from CIHR and Campus Alberta to fund this two-day summit. It was held at the University of Calgary. So the prime objective was really to bring together stakeholders, not only just researchers, but health practitioners, policymakers, health professionals, to discuss and facilitate how we can actually reduce weight bias in the province of Alberta through various research initiatives in education, in healthcare, and in public policy. So we had representation from all of these sectors to really have fruitful discussions that we can actually address these issues in different sectors. So these are some of the organizations that were featured. We had 40 participants representing various different sectors, so education, healthcare, and public policy. We had representation from Alberta, from Ontario, and BC, and we had really great discussions that we came up with a lot of research directions on how we can address weight bias in Canada. So the 6 of these were the main themes for research that deserves more attention in the discussions that we had. One was measurement. So if we can't actually measure weight bias properly, how do we actually know that we're able to reduce it? So measurement was a really important one. Interventions to reduce weight bias, not just amongst healthcare professionals, but also in teachers and educators. The qualitative research and lived experience was a very important one as well. And actually, here at the summit, we've noticed that we have the weight of living, and we've had all these experiences that we hear from our public engagement committee. And this is something that very much in line with hearing that qualitative experience and lived experience, those personal stories and personal narratives that are so powerful and also very difficult to hear. We also had the fourth categories to learn from other forms of discrimination, so other stigmatized groups. Their fifth category was the root causes, addressing these, really understanding why do we have weight bias, why is it so pervasive in society, and lastly is the cost of weight bias. Not just the economic cost, but really the personal human cost of weight bias. So we actually published the results of this summit, and we published this last year in Obesity. So we discussed all the future research directions. The purpose really of this article was to promote collaboration, promote interdisciplinarity in this field, and promote more research collaborations amongst different sectors so we can really advance the field and reduce weight bias in these sectors. So I'll speak mostly about measurement interventions. These were 2 sectors in research that we really addressed after this summit. The first one, I'm happy to say, just got accepted for publication in Obesity Facts. So we actually did a systematic review looking at self-reported weight bias questionnaires. And we found that there were 40 original questionnaires. There were other revised ones that came after that, but we actually revised them for their psychometric properties, because it is really important to choose the appropriate questionnaire for what you want to measure, making sure it's reliable and valid. And so we just got this accepted recently. And what we found was that there's so many different questionnaires that can be used in different population groups. So I would advise you that if you do want to actually measure weight bias in your population group, whether it's practitioners, researchers, students, that you may want to look at what kinds of questionnaires are really geared towards and catered for that audience, because there are several for parents, health professionals, etc. The interesting thing that we found too from these self-reported questionnaires is that they didn't use person-first terminology. So this may actually be quite offensive just based on the terminology that is used in asking these questions about their attitudes and beliefs about obesity. So we also conducted a systematic review of weight bias reduction interventions. So we're really excited about all these articles that we had to read in abstracts. But we did actually find that there were 17 weight bias reduction interventions. So very few of these studies actually exist, and they're in very mixed samples of mostly students in training, very few in practicing healthcare professionals. And the sad thing is that there is no one magic way to address weight bias. There are several different key messages that are important to include in any intervention to address weight bias, and it can't just be on education, and I'll speak about those in a second. So because there was so much heterogeneity in these studies that it was difficult to actually decipher what are the key successful tools and how we actually approach weight bias reduction. We need to actually move beyond awareness and promoting skills and competency in addressing obesity, and also empathy in relationships with people living with obesity. And of course, we can't do this without changing social norms. This isn't going to exist just by addressing it in healthcare, of course. It does require change in social norms in the way we speak about things. So as Dr. Yanni Friedhoff actually mentioned yesterday too, it's important to actually do all the little advocacy efforts that we can and wherever we're working, and I think that can help us address this at a societal level. So some of the key messages of those weight bias reduction interventions, the first one is presenting facts about the uncontrollable and non-modifiable causes of obesity. These include genetics, biology, sociocultural influences, and the environment. But like I mentioned before, education on its own, just having these presentations, are not enough to reduce weight bias. We do have to include other key messages incorporated in these interventions, one being education, and I'll mention the other three now. The second one here, there's a couple of celebrities here in the room featured in these pictures, but the second one would be to invoke empathy with positive contact with patients living with obesity. And this, luckily, we have the Canadian Obesity Network Perfect at Any Size image bank that can be used free of charge, just accepting the rules and regulations of using these pictures, and they can be used in your presentations. I'd encourage usage of this amongst yourselves, but also of your colleagues and friends in all different sectors. So we published this in Clinical Obesity last year as well. The third key message is having peer modeling and shadowing with empathetic experts. So it's important to really have good modeling from behaviors of experts that are well-versed in obesity so that we can learn from them. But this also applies to parents, being a peer model for their children, and also for teachers who are trying to teach their students as well. It's really important to be shadowed by experts that exude empathy. This fourth method is repeated exposure with patients over the long term. We do know that health professionals have very limited time with their patients usually in their clinical interactions, but exposure over the long term in these types of interventions, not just a one-time fits-all approach of contact with a person living with obesity, but repeated exposure could be really helpful in reducing weight bias. So these were the main outcomes that came out of the second Weight Bias Summit, and because we still want to continue with more summits and work on those research advances that we did from the second Weight Bias Summit, so my colleagues and I, so actually spearheaded by Ximena, we organized the Everybody Matters third Weight Bias Summit, and many of you also were in this room that were present at this. And we organized this to really move beyond awareness and really to create change. And this was conducted in Edmonton in 2016. So the objectives here were a little bit different from the previous two summits in that here we want to share best practices and we want to come up with communal key messages that could be transferred across sectors. We want to see what we really agree on, and we want to be used in future interventions to reduce weight bias. So this is just our poster that we used to advertise it, and we had many people actually from the Public Engagement Committee that were present at this. and we really want to have the patient voice as well included in our talks. This is just a picture of what our setup looked like for the Third Weight Bias Summit. We had lots of really great discussions. We organized it in a U-shape so we could really interact with each other. We really started off with lots of presentations from key experts in the field, hearing about what we know so far about the prevalence, consequences, learning from other models of discrimination, to really understand how we can apply what's already been done, what we know from the past, and how we can apply that to weight bias reduction as well. It was really a great 2 days. So these are the key messages that we found from the Third Weight Bias Summit. The thing is that was important to understand was that there are key messages that were important to certain sectors, so they differed slightly depending on what sector, healthcare, education, or public policy. One thing we did strongly agree on is that weight bias will not be tolerated in education, healthcare, public policy, and that obesity should be treated and recognized as a chronic disease in healthcare and policy sectors. However, it was important to note too that we had a lot of education professionals part of our group in our discussions, and we noticed that it's really important to decouple weight and health, especially in education, where a lot of prevention initiatives can be really quite harmful to children and adolescents if they're not messaged and spoken about nicely and sensitively. So this is a manuscript that's actually under review. We will wait to hear the results of those. So other key messages were that we really want to prioritize strategies to weight bias reduction and discrimination. One of the things that we really want to do is create resources for policymakers so that they have this information at their discretion and their availability. Nothing about me without me. So we actually presented a workshop yesterday with Public Engagement Committee members, and we really just thought it's crucial, absolutely important to include the patient voice, the public voice, in all of our endeavors. It's really important to understand at the beginning, during, and at the end as well, for knowledge translation too. And we obviously also need developing a better obesity definition, which Arya spoke about yesterday and very many times on his blog. But this is something that was really iterated strongly at this Third Weight Bias Summit. Now, this is not the only advocacy initiatives that have been done amongst ourselves as colleagues, but also from the Canadian Obesity Network. But here there's a dietitian in Manitoba who was really trying to push a bill forth. And this bill, called Bill 207, really wanted to introduce physical size and weight obesity under the Human Rights Code. So this just goes to show you that local, individual, all these advocacy efforts, they all matter. And I think it's important that we can all do that together and not just in silos. Some of the key messages are some key strategies for weight bias reduction interventions, and these include presenting uncontrollable facts about obesity, so the education component is of course still very important, evoking empathy by positive contact with patients living with obesity, peer modeling with empathic experts, and of course repeated exposure with patients over the long term, not just a one exposure with patients and empathetic experts. So I'm bringing this picture back again because I want us to also realize that the stereotypes that we had and that we're acknowledging at the beginning of this presentation are very important. It's very important for us to be aware and have self-reflection on some of our biases and attitudes, because this can really change behavior. If we are aware of these judgments and beliefs and attitudes, we can often enact change. It's important for us to speak up and be advocates all together, and I think we could really make a change. So before I conclude, I really want to thank the Everybody Matters Collaborative. I feel so lucky to be working with such amazing women, featured here in several different talks that we've done together, and this one as well. This was all a collaborative effort from all the women that were featured here. And I'd just like to thank some of my funders from my postdoctoral fellowship, and just my contact information in case anyone has any questions. Thank you.
Thank you, Angela. She said it would be 17 minutes. It's 17 minutes and 24 seconds. Wow.
That was a lucky guess.
Are there any questions for her? That's amazing. Yeah.
Angela, I just want to say that you're nothing about me without me has been accepted and is carried through in the U.S. It's carried through in England. It's carried through in Ireland. It's carried through with the Aswaks. We call it something just slightly different. It's nothing about us without us. So thank you.
I'm glad to hear that.
Thank you.
Oh, hi, Sean.
We're talking, how do you propose to impact people like Senator Ogilvy? Statements, I don't know if you know what he said in the past, but he's an academic. He's a big guy. He's a very smart guy. Get cycle leader in RA applications. So we can see that, and yet somebody that right is making these type of statements. Where do you go from there? Why did that happen?
Yeah. I ask myself that often, John. And I know he's part of the Senate report too on obesity that was published in 2016. And actually, some of the things were quite weight biased as part of that Senate report too. And it's really difficult to understand how someone so knowledgeable in so many different aspects can still have such weight bias attitudes. Well, I don't think it's just going to be one conversation with this type of person or other people that are really going to improve our attitudes and beliefs about obesity, but perhaps repeated exposure, repeated contact with experts in the field like yourself and Aria and others who have really shown credibility to suggest, look at the negative impacts of these kinds of attitudes and beliefs. And if we continue with that, well then nothing's going to improve. Not only just our quality of care for our patients, but quality of life and mental and physical health. So I really don't think there's just one way of addressing it. I think continuously doing professional development is really, really important. And the education system starting young, starting with our students and our medical professionals to be, our pre-service professionals. I think that kind of exposure early on in their undergraduate degree is really important so that perhaps when they're older, they'll keep those positive training with them. And consistent exposure to people, I mean, that have been really well-versed in this field and knowledgeable, I think is what I would say. It's not going to be a one-time conversation on these, what did Yanni say yesterday, these website trolls? I think it's going to have to be more than just commenting in those comment sections, like having conversations, going to conferences, maybe even doing professional development at a higher governmental level, not enforcing, but at least making a mandatory training for all people in government and policy as well. We talked about that at the Third Weight Bias Summit. I think those are just some of my ideas. Marty? Oh, sorry.
Okay, so because I know you so well, later, we've run out of time for questions.
That's fine. Thank you.
Sorry, Marty. I'm sure you had a great comment, but we'll make sure we save time at the end. I just have a quick question because I just got a bit of a concerning announcement on the website that said the plenary talk is at 5 in this room, and that's impossible because we're here till 5:30. So I'm going to run out and fix that error, but carry on. If I don't make it back, we'll just carry on. I need to fix that. So our next speaker is Dr. Sara Kirk. So Dr. Kirk is going to be talking about addressing weight bias in healthcare through interprofessional health education. Dr. Kirk is a professor of health promotion at Dalhousie University with cross appointments to the IWK Health Center and Mount St. Vincent University, Halifax. So please join me in welcoming Dr. Sara Kirk.
And I'm just going to address Sean's point, actually. So this chappie is actually a Nova Scotia MP, so I will be getting in touch with him and pointing out the error of his ways in terms of what he said. Okay, so I also want to echo my thanks to the committee, the organising committee, for inviting me to speak here this afternoon. And I'm going to follow on from the excellent presentation that Angela's just done and talk about some of the work that we've been doing in Nova Scotia to actually start moving forward in addressing weight bias and stigma through interprofessional health education. I'm keeping an eye on my time. I haven't timed myself, so... Just to give some faculty my disclosures, the funding for the research that I'm going to talk about comes from the Nova Scotia Health Research Foundation and CIHR, but I also hold funding from other places as well, Heart and Stroke Foundation and Lawson Foundation. But I do not believe there are any biases, don't have any commercial support, and so I think that's not applicable. So the objectives that I've actually put on this slide differ from the ones that are in the little app thing. But essentially what I want to do this afternoon, I'm going to provide an overview of the research that we did that actually led to the work that I'm going to talk about. And what we tried to do in our research was understand the perspectives of people with obesity, their healthcare providers and policymakers in relation to obesity management in Nova Scotia. I'm also going to share how this research then informed the development of an evidence-based interprofessional health education workshop designed to reduce weight bias and stigma in healthcare, and give you some of the preliminary data that we have from our evaluations around how the workshop is actually helping to reduce anti-fat attitudes among our participants. So this builds on research that we conducted in several years ago now. The knowledge to action gap is sort of strongly focused here, in the sense that we published this research in 2014. I actually do not have any funding to continue this work, but still feel very passionately that we need to be presenting it, and so it's something that I'm actually funded myself pretty much to come to present this work at various places, because I think it's so important that we get this out. But we were looking at weight management within the Nova Scotia system from multiple perspectives. So we were looking at the views of individuals living with obesity, their healthcare providers, and policymakers. So we really wanted to understand those people who actually are setting the budgets, for example, around what gets funded within the healthcare system of Nova Scotia, as well as understand sort of both sides, if you like, of the therapeutic relationship. And we're actually was the first study to explore this issue from multiple perspectives, albeit just in Nova Scotia, which, as everybody knows, is a rather small province, one of the smaller provinces. And we actually also, just to give a little shout out to our last paper, so we actually took the data from the original study that we did, and we published another paper which was actually published last week, where we actually, again, reanalyzed the transcripts that we received, and we put a different framing on it. So we actually used a social ecological framing and a mental health and well-being framework as well on the data, and say that's just been published if anybody's interested in taking a read of that one. And what we heard, similar to what has been coming out in other presentations over the course of the summit so far, is that weight is a sensitive topic to address. What we were finding is that people talked about how their weight was either not addressed, even though they perhaps wanted it to be, or it was addressed when they didn't want it to be. And of course, we've heard that in other studies as well, this idea that, you go in with an ingrown toenail and suddenly somebody's talking about your weight, or people just don't know how to deal with it, and so it's just sort of buried. And what we didn't hear was around, again, that what we're hearing, what we're now talking a lot more about, around how we need to be thinking more about health than weight. So it really kind of reinforced in my mind that was the way that we need to go. And I think it's also important to say at this point in time that I, like many of you, have had a journey myself in terms of my attitudes about this kind of work and what I feel is important moving forward. I have used and promoted BMI, for example, in previous work that I now sort of think actually that's perhaps not the best way forward. So I think it's also something I think we all need to sort of recognize. This is an evolving field. We make mistakes. And certainly from the people that we spoke to, the healthcare providers actually felt pretty bad about the lack of opportunities they have to address weight and health within the kind of current framing of obesity management. So I think we all need to acknowledge that sometimes we do things and we do them with the best intentions, and it doesn't always work out that way. But it certainly raised this kind of question, and I'm going to come back to this point as well, about why is it so hard to let go of weight as a metric? We'd really, really struggle with that. We heard about the privileged position of the practitioner, and what that really means is that we when you're trained as a healthcare provider, you do come with a very, very different sort of level, if you like, when you're in that therapeutic relationship. And sometimes it's hard for people to actually, raise the issue. So you can have all the intentions of going in to see your healthcare provider about something, and even I can, feel like this. Sometimes you want to go in there they look harassed, they don't look like they've got the time to talk to you, and so that then kind of cuts off any conversation that you might have had. And sometimes we forget that there's a person at the end of all of this, or a patient. I personally hate using the word patient. I do people-centered research, I do population-centered research, but that's the way it's framed. And one of the other things that really came out was this idea of support versus dependency. So the individuals living with obesity really were looking for support. They wanted something that was a relationship over the longer term that would help them to address some of the challenges that they were facing. The healthcare providers came up with this idea that this was something that would actually create dependency. So if we were giving people support, maybe we would actually create dependency. And somebody actually asked me earlier this afternoon, would you like to sort of unpack that more? And I was thinking, yeah, actually, that's a really interesting point that I think we perhaps do need to do more exploration on. Where does that come from? But we also heard about the need for communication skills, both verbal and non-verbal. We struggle sometimes to know what words to use, and sometimes it's something that we perhaps do need to sort of be very careful about our language, and that comes from also the expressions that we use as well. So we call these the dialogues of condemnation. So this is actually from our most recent paper, talking about mental health and well-being in the sample that we had. And these are a couple of things that people said. So there's such a stigma there that is reinforced. But when I enter the health system, the first place I expect to talk candidly about my issue, I hear the blame. Well, if you eat right and exercise, you'll lose weight. It's as simple as that. It's a simple thing. That's what I get. It's so simple. And of course, we've heard that again, time and time again over recent years. The second quote, there aren't supports for people that are trying to lose weight. And sometimes I don't feel like the doctors are really on board. They think it is a food issue and that's it. So I don't feel like the supports are there for those people. So these are the kind of things, and again, we've heard it from other people over the course of this of the summit, that I think really speak to the challenges that we're still facing around knowing what to say, knowing how to say it. And it comes very much from a place where, with students training, how do we actually get them to think about things differently? And so the next thing that we did, so we got this incredibly rich data, and we wanted to do something with it from a knowledge translation perspective. So we took the interview data and we actually scripted it into a dramatic presentation. The URL is at the bottom there, but again, if anybody's interested, I'm more than happy to tweet it or share it with you via email. And we wanted it to be this sort of like this kind of common interactions between patient and the healthcare provider in the form of this short dramatic presentation. So we had to, obviously there was a little bit of poetic license to help it to kind of join together. But these are the words, so this 14-minute drama actually is the words that people spoke. The unspoken words come to the audience, and the spoken words are between the two characters, and there's only the two characters. And it looks like a doctor, fair enough. It could be any healthcare provider. But it really highlighted the spoken and unspoken tensions that our participants described. And then what we did with that, so we did the 14-minute drama, and then we've incorporated that into a 3-hour interprofessional workshop that we've actually sort of trained around 700 healthcare providers and more often students since we started with this. And what we get our participants to do, so this builds, again, you heard from Angela about the things that we know that we need to be doing. And so one of the things we sort of focus on is challenging the myths about the controllability of weight. We show the dramatic presentation. If we have the funding, we actually bring in live actors. We bring in actors to do it live. So yeah, a bit of a slip there. And that is much, much more powerful than doing it through the video. And partly because the actors, we have great actors who are actually, one of them is a simulated patient, so kind of works with the students a lot of the time anyway, so it's a really great manner with them, and they actually then sort of involve themselves in the rest of the workshop as well, so they're not just there for their 15 minutes of fame, if you like. And then we do group work. So we actually get the groups to, we make sure that they're interprofessional, because you know how people always want to hang out with their friends in the same course. So we actually make them work in interprofessional groups, so they learn a little bit more about what other people are doing and how other people might be working in this space. And we get them to rewrite the script, so they see this kind of negative video. And you know, trust me, we tried very hard to make it a more positive. We actually tried to find sort of good examples, but there simply weren't anything in the data that we had. So I think that really speaks to, again, the sort of like the challenges that we have. It's just not always a positive experience. And we get them to rewrite it with a focus on what the characters are saying, as well as the non-verbal cues. So, for example, in one part of the drama, the patient character, if you like, sort of talks about the absolute look of disgust on the doctor's face when they went in to have their blood pressure taken. And so we focus on things like that. We focus on things like the types of chairs that are available, and not having chairs with arms. We've also done these sort of pre-post measurements of attitudes, actually using the anti-fat attitudes test. So is it effective? Well, yep, so far we've found it to be very, very powerful as a way of getting people to think about and reflect on their practice. So in terms of their usefulness in helping our participants to understand the topic of weight bias and stigma, we're scoring 4.5 out of 5. Similar for reflecting on weight biases and stereotypes, and also in terms of usefulness in future practice. And what we've seen we've got a smaller sample that we've done the anti-fat attitudes test sort of pre and post, but what we have found is significant reductions pre and post workshop. And our most recent group of students, we've actually done it, we're waiting for it to be a month when we can actually do a 1 month post assessment as well, so we can actually see whether or not it makes any difference. Those reductions actually are maintained over time. What our participants say about this opportunity is that it, you know, for example, this very eloquent response to, and actually I think this is somebody who came up and talked to me afterwards about how powerful she'd found it as well. So it really educated me on the topic of overweight in the health setting. I've always felt that it's a sensitive topic, and that someone who is overweight should not be judged, as it's not just behavioural but biological as well. But now I feel as though I have a reason to defend this, again, going back to that idea of advocacy, and feel more encouraged to promote awareness about body weight, and that our society in Canada should be more sensitive and knowledgeable about this topic. And this one comment about, I like how it incorporated different health professions, and it made me critically think about the stigma behind weight. It showed me so much that I did not know. And this one, I liked rewriting the narrative. I felt that this was a very effective way to dissect the hidden script behind the scenes and understand what was fully going on. And certainly when we walk around the groups and sort of talk to them, we really see that kind of that engagement that they have. They do find it very powerful. And so sometimes we're able to get the actors to sort of walk out and actually re-deliver those rewritten scripts as well. So what we're trying to do in moving forward, we want to continue to analyse the data that we have, so looking at attitudes over time. I have a master's student at the moment who's also going to be looking at this among dietetic trainees at Mount St Vincent, where they train dietitians, and we want to actually introduce a control group there as well, so that we can see whether or not there's a difference in people who don't get exposed to the intervention, because that's the other area that's lacking. And we want to do some more research on whether it's actually reducing weight bias in healthcare. So when these students actually go into practice, is it actually changing the way that they do their practice? We're hoping to sort of look at maybe doing some online training modules. I did do one of these massive open online courses last year, or no, 2 years ago, cracky. Again, would like to sort of incorporate more of this into that feature. And also continuing to support the work that we've been doing in the Everybody Matters collaborative in terms of reducing weight bias. I mentioned again that this issue about letting go of the weight, the uncontrollability of weight. I almost had a stand-up row, I guess, with a heated debate, maybe is perhaps a better way of describing it, with some of the students who simply could not. I could see, when you're looking out and you see this look of incredulity that we could possibly be talking about letting go of weight, but and I think that's something that we've really, that's so ripe for further exploration. And that's it. I'm on 16 minutes and 26 seconds. Thank you very much.
Thank you, Sara. Does anyone have any questions? We have time for maybe one or two at most.
Okay, so the question was, I think, just around the issue of reducing weight bias in dietitians when there are particular kind of clinical issues that need to be addressed. Yeah? Or words to that effect. I'm really looking forward to the work that we're going to be doing on dietitians. I think it's going to be very interesting to see what, and particularly to look at it in comparison with the interprofessional model that we have as well. I actually think that dietitians are probably one of the professions that are really stepping up to the plate, though, in terms of addressing weight bias and stigma. And I have to kind of sort of confess that I often call myself a recovering dietitian. I actually trained as a dietitian many years ago. I would say that things have changed quite a lot in the profession. I'm not a dietitian anymore. I can't call myself one. I'm not. I refuse to sit an exam at my age, but it's but I think it's something that would be very interesting to look at more. Yeah.
I have to cut you off.
Yeah. Are we going to be kicked out of the room?
We will soon. Thank you. No, that's okay. Yeah. There was a recall on the correction, so the 5:30 talk will happen. I want to just keep moving because I want to leave lots of time then for Ximena, Ramos, Salas. So Ximena is going to be talking about addressing weight bias in public health, changing the narrative to avoid unintended consequences. Ximena Ramos Salas is a PhD candidate at the University of Alberta School of Public Health and the Managing Director of the Canadian Obesity Network. So please welcome Dr. Salas.
I haven't defended my thesis. I'm not a doctor yet. But thanks. Maybe I'll just quit now. No, I'm kidding. Okay, no, I'm not allowed. I will finish. I will finish. It is difficult with two jobs, but so here we go. So I'm going to present you some research that I'm doing in public health. My committee members here, Dr. Forhan, my PhD supervisor is also here in the room. I don't see her. There she is. Yeah. So I haven't talked to my PhD supervisor for a while because I've been busy, but she's going to hear some things now. So conflicts of interest, I really just wanted to, again, mention that I received consulting fee from CON and from WHO, and I've had funding from CIHR, from the PICTIP training program from CIHR, and this is part of my research, so mitigating bias by, we had ethics approval, and my PhD committee has been providing guidance. So the objectives are really, for today, is to review some of the key concepts of weight bias and stigma, and to apply those concepts as they relate to public health, and then discuss some strategies for how we can change this. So stigma, we know from decades of research in other areas, not obesity, but also obesity, stigma is an added burden that affects people above and beyond any impairments that they may have. So if you have a mental health issue or a disability, when you experience stigma, that is an added burden on your health. And so we know that this is an important public health issue. So just to clarify, Angela explained some of the types of weight bias, but I just wanted to talk a little bit of the theory and the mechanisms of how weight bias works. And so weight bias are your personal beliefs about obesity, your attitudes internally. But weight stigma is more about the social stereotypes that we talk about in obesity and how those attitudes that we have personally convert into social stereotypes. And then those social stereotypes can lead to weight-based discrimination. And weight-based discrimination is when we act and do something about our personal beliefs. So these concepts are interrelated. Our own internal personal beliefs about obesity can cause social stereotypes and stigma, and those social stereotypes and stigma can lead to people experiencing discrimination. So we know from the Red Center for Food Policy and Obesity, Rebecca Poole is the guru of weight bias, that weight bias is pervasive across education, workplaces, healthcare, and the media. So there's no denial that we have enough data out there that weight bias is prevalent in our society and it's pervasive. 63% of children experience bullying in schools because of their weight. 54% of adults experience weight bias in the workplace. 64% of adults experience weight bias from a healthcare professional, and 72% of images we see out there in the media have weight bias. So Rebecca Poole has come up with various models and theoretical models on how weight bias affects individual health, but as you can see on your left side, you can see the population health impacts of weight bias, which is the focus of my PhD. So when we have weight bias in public health strategies, we tend to simplify obesity as an eat less, move more, and that tends to lead to strategies that disregard the complex issues of obesity and the complex causes of obesity. We also know that that simplification of obesity can actually impair obesity prevention efforts and increase health disparities, as well as increase social inequities. So we know this is well established and can increase morbidity and mortality. So the reason why I decided to do my PhD on weight bias and stigma in public health is because I started to see these images. And this is a public health campaign from Atlanta, Georgia in 2012. And it uses shame and negative fear tactics to encourage parental and family behavior change. The idea that, if you don't do anything about your weight or your child's weight, your child's gonna live a shorter life, and we have to do something about it. It's that kind of like urgency. And like Sara was talking about earlier, I've used that language before. I don't know how many obesity grants I have written where I talk about how this is a public health crisis and we need to eradicate it, we need to tackle it, we need to fight it. And so I'm guilty of it as well. And so I started seeing these pictures. And so I said, well, are public health strategies contributing to weight bias? Are they feeding on the social stigma that we have about obesity? And so that's why I decided to do my PhD. What I do know from research, when I started looking into this, I started questioning, why are we doing these strategies? And I found out that shaming does not change behaviors. So none of those strategies that we're doing are actually doing what we're trying to achieve, which is to improve healthy eating, reduce physical inactivity, improve the health and well-being of Canadians. And then I started looking more, and I had discussions with Rebecca Poole, who is one of my mentors, as long as everybody here on the Everybody Matters Collaborative. And I said to her, do you think public health is contributing to this? And she said, this is interesting. We have measured weight bias amongst healthcare professionals, but we know public health people, we're good. We do good things. And so she's like, yeah, let me look into this. And so she actually has a huge database of patients with people with obesity. And so she started looking at this. You know, she showed people campaigns, public health campaigns, and started asking them, what do you think about these campaigns? And so what we found out is that stigmatizing campaign messages are rated worse amongst people with obesity. They're considered the most stigmatizing, and they actually show the lowest intent to comply with the messages that we give. And then they also, she also asked, what messages do you actually prefer? And they said, well, we prefer messages that focus on behavior changes, not weight. And those had the highest rates. And then she said, she also looked into, okay, so what about messages that don't mention obesity at all? And those were the most motivating. So I was like, okay, we gotta change this. So started looking into like, who else is looking into this? And so I found lots of people critiquing public health, obesity, public health campaigns. It wasn't just us. And so the critique is that public health campaigns are contributing to the change socially about what we perceive as a socially acceptable body size. We also found that it's considering the public health campaigns can also contribute to inaccuracies about what causes obesity, because the simple messages about its activity and exercise, it's not accurate entirely. And we also found out that many critiques out there about, you know, public health trying to really quantify health in a number, which is not helpful, and public health strategies ignoring the impact of other social factors and determinants of obesity. And mostly the fat acceptance community and the critical weight scholars believe that it's promoting an oppressive ideology of moralizing weight. You know, if you have obesity, you're obviously failing as an individual, as a citizen, you're contributing to the burden of obesity, of healthcare costs, and you're a problem. And so it's moralizing, and it's causing an oppressive ideology for people living with this disease. So then I started looking at, okay, so what do Canadian public health policies say? And so I did a critical review about all the provincial strategies for obesity prevention, where I could find them. And what I found was that childhood obesity is the most problematized issue in public health prevention policies. And the idea of that is that if we intervene in children, we can prevent it from happening. I also found that the narrative of eat less and move more is pervasive, and that the obesity frames used in these public health policies tend to be more about, you know, targeting individual behavior change. Although we talk about the complexity of obesity, most of the strategies are focusing on let's teach people to eat healthy and let's get people to exercise more. I also found a heavy message about there is like a truth about that there is a healthy weight. And that healthy weight is measured in a certain BMI and a certain weight, a certain size. And so it's in all our policies. It's in WHO documents. There's that narrative that, you know, you can achieve healthy weight, and it is an established truth in public health. Obesity is also framed not as a chronic disease, it's framed as a risk factor for other chronic diseases. And people with obesity are not engaged in public health obesity prevention strategies. And weight bias is sometimes discussed, like the report from BC, but in most policies, it's not addressed at all. Then I interviewed and had a narrative inquiry with people living with obesity, and I asked them, so what do you think about these? And they said, public health obesity narratives do not reflect my reality. Weight-centric approaches are not helpful. Eat less, move more narratives leads to social judgments about me as an individual. The risk factor approach is not consistent with my clinical management approach that I'm trying to do through the healthcare system, so it's confusing. And the prevention policies silence the need for treatment. They also told me that there's clearly a lack of engagement of them as individuals in the development of public health obesity prevention programs. Here's a quote, and famous people on the picture again. The public health word obesity tells the world that obesity is bad. obesity and people with obesity are a burden to society. This narrative has an impact on public perception. When I walk down the street, I will have strangers telling me, you know that obesity is unhealthy, right? You should lose weight, or you should not be eating that, or you should be taking the stairs instead of the elevator. So obviously, our messages out there are affecting people at the individual level, even though our population health strategies are intended as a population health approaches. This narrative is so pervasive in our society that it actually impacts the experiences that people with obesity have. The eat less, move message did not go well either. When I deconstruct this message, it says to me that public health professionals believe I did this to myself, so they don't need to help me find evidence-based treatments. The eat less, move more message makes it sound really simple, doesn't it? But my journey has not been simple. It has been difficult for me. Every day is difficult. The healthy weight narrative definitely does not go down well. I have lost over 100 pounds and I am managing my disease well, but I still have obesity according to the BMI categories. My goal is to maintain this weight loss. Based on what I am doing now, I cannot eat less and I cannot exercise more. So I will never achieve the healthy weight range promoted through public health campaigns. I am at my best weight and I need to accept that. Why is public health not okay with that? So then I summarized some of those findings from my narrative inquiry with people with obesity that, the causes of obesity are complex and vary from individual to individual. So having generic statements about what causes obesity is not really helpful. People with obesity experience weight bias across their lives, from their family members, their peers, their work colleagues, in the media, everywhere. This results in a lot of social isolation, depression, anxiety, low self-esteem, poor body image, suicidal acts and thoughts, and overall poor quality of life, which is already established in the science and the evidence out there. And patients who have had bariatric surgery experience additional stigmatization because of their decision to have surgery, and individuals internalize stigma and develop unhealthy coping mechanisms. So then I said, okay, well, let's talk to policymakers who work in obesity prevention. What do they say? And so I found that people who work in public health and obesity prevention strategies have two different frames. There is that biomedical frame that is obesity is all about energy in and energy out, and there's that social ecological frame that obesity is really caused by the environment, and the environment is basically making everybody make unhealthy choices, which also kind of like promotes that idea that we do make a choice about obesity. Public health is about improving population health, so we don't really deal with individuals, so our messages are really intended for populations, and so we really are not aware of what's happening at the individual level and how they're perceived at the individual level. Public health approaches have good intentions, but we tend to use obesity as a hook to promote healthy eating and exercise. And weight and BMI is really a population health tool. Everybody I talk to understands that, but it's the only tool we have, and so we really need a number. There's a really strong need for a number, and they could not get away from that. Obesity is a risk factor for chronic diseases, not a disease in itself. Strong belief in that. Political barriers to implement comprehensive obesity strategies are clearly came up a lot in my interviews. That even though some people agree that we need to have more comprehensive obesity prevention and actually implement them, because the reality is we haven't implemented a lot. There were barriers at political and institutional level on how to implement them. And increasingly, policymakers are becoming more and more concerned that their strategies are too weight-centric. So there is kind of like a trend that policymakers are reflecting on this. And some of them also talked about how we need to have a paradigm shift in public health to move beyond weight and focus on health. So here's one quote from a policymaker. The political aspect of public health cannot be understated. Political influences also present a barrier for systems thinking in public health. In order to prevent diseases, we need to have a better understanding of the larger forces that influence behaviors. In the field of obesity prevention, we need a shift in paradigm. By shifting paradigms is challenging. We work in a medical paradigm. This is our story. This is how we live our professional lives. So, to summarize, what can we do to address weight bias? This is where we had the Weight Bias Summit. But my recommendations are recognize weight bias as a public health issue and as a social justice issue, monitor weight bias at the population level and how it affects the population, create policies to prevent and eliminate weight bias and stigma, and assess the unintended consequences of all our programming. Look at the values behind our strategies, consider the language, the images, everything. I also think that we need to treat obesity as a chronic disease and talk about obesity as a chronic disease in public health and leverage existing chronic disease frameworks, create and talk about promoting chronic disease prevention as opposed to just tailoring everything on obesity, develop people-centered public health approaches. And also, in terms of people-centered approaches, there's an opportunity for public health to really consider the complexity of obesity and their experiences and give people a voice, engage them, and shift from the individual behavior to focus on well-being for the whole population and empower individuals to participate in policy. And finally, these are my more provocative recommendations. Aim healthy eating and physical activity strategies and messages for the entire population without specifically targeting people with obesity. Consider if obesity needs to be mentioned at all in health promotion and wellness campaigns. Challenge the healthy weight messaging by shifting focus to health and move away from quantifying numbers. And promote body diversity in public health campaigns. Challenge the individual choice narrative and the energy in and energy out narrative, and adopt people first language, and change the portrayal of individuals with obesity through imaging. So here's a few questions that you can ask yourself, and I will leave them there for you. And that's it.
Thank you, Ximena. And I apologize, we have run out of time for questions, but I want to thank all of the speakers for such a wonderful presentation. I know they're all very accessible and be more than happy to chat with you. And please stay as we have the distinguished lecture presentation will be taking place momentarily in this room. So thank you again.